I'd like to introduce our next speaker, and that is Al Cardillo. Al is the president of the Home Care Association of New York State. He has been fighting in the trenches for how long, Al? Too long. And he used to look like this, his picture that he gave us in the program. So this is the same guy. It is Al that's up here right now. So Greg gave us a nice picture too. I'm gonna go get my baby picture next year and put it up there. But with that, Al Cardillo.
Thank you, everyone, and thank you, Lou. I want to say I didn't give Lou that picture. I don't know where he fished it from, but I do want to say that, when I first came into the field, my hair was even a lot darker than that, and I looked a lot younger, and it really kind of apropos for what I want to just say. So for as many decades as I've been in this field, there's never been a director of the Office for Aging like Greg Olson. So I just want to recognize that. And I think that's really important. It really is a little bit of a table setter for what I'm going to talk about and how I'm going to really radically shorten my remarks so we can get back on track with our timing and with the whole program. I just want to see if this is going to be working okay. Okay, let's see if okay, there we go. Okay, so Lou, I want to again acknowledge you and Beth and all the work that you've done. It's amazing that you've been doing this all of these years, and just look at the breadth of the energy and the talent and the passion that's in this room and clearly in the virtual space where we just saw the chat really going wild during some of the discussions, which is great. This is what we have to harness if we really want the system to function really the way it needs to, which is really revolving around the patient. So I'm going to truncate a lot of what I said, and I'm going to really focus on a direction of vision that we see and that we think is really, really necessary in this system to make it work better, to make it work right, which is really the idea of a New York home care first policy. See if I can make that go. So I'm not going to sing this song from the Byrds, but I was tempted. But this is the song Turn, Turn, Turn. There's a time for every purpose. And if there was ever a time, it's really long ago, but if there was ever a time, it certainly has been made manifest to us as we've looked at everything that's happened in the pandemic, and we just look at the need that's out there and the gaps that are out there in services. Just doesn't want to be responsive. Okay, so I start with this slide here because this is Article 36 from 1977. It was the Declaration of Findings and Intent, and this is emblazoned in the public health law in New York. The legislature hereby finds and declares that the provision of high-quality home care services to residents of New York State is a priority concern and should be a primary focus of the state's actions. So that was 45 years ago, and obviously well ahead of its time. I think this is really critical for, I can't advance the slide, I guess so. But this is very, very critical for where we are today, and I think reflective of what we heard a bit this morning. One of the first things I want to say is if that was 45 years ago and that statute created a corpus for healthcare planning, a focus of where home care was in the context of overall state policy, created a bureau dedicated to home care, created a state council. Which one? Okay, so I want to go backwards. Okay, created a state council for home care, created structure and planning for home care as it would relate to nursing home bed building and offsets to all of that. That was the policy 45 years ago. And for a number of years, well into the 80s, maybe touching point on the 90s, it was a cohesive policy. And in those years, if there were Medicaid cuts, they weren't aimed to home care because home care was being supported financially and otherwise with the idea that it needed to grow, that we needed accessibility. So now that we're on this slide, the surprise is spoiled, but where have you gone, Joe DiMaggio? Where have you gone from a policy that in 1977 actually laid out a national vision for where home and community-based services should go? And that policy did create the template for the home and community-based waiver program in 81 and all of the other things that really ensued. One of the things that's happened is if you look closely at that slide, you see the little home care icon at the bottom of the scrum. And it's not so much that the state just decided, well, we're not going to do home care anymore. It's that layer upon layer of other policies and other issues really buries home care underneath the scrum. So you have new policies, new directions, new things that have been done. Managed care. You have, an array of new programs and services and new ideas and new thoughts. But what you have at the bottom of that scrum, very hard to find, is home care. So one of the things that I think really typifies it is that if you listen to the discussion earlier about all the things that are in the budget, how many of those things struck you as saying those are cohesive with a coordinated focused state policy on home care, and how many of those things that were done, even going back to this MRT2, that are completely regressive, that are adverse to the very system that we're supposed to be saying this is the focal point for where we're going in healthcare and long-term care and so on. So I think one thing that's important as we go forward is to really understand what is the structural context. Is it that scrum we just saw? What is the structural context when we talk about home care and we talk about these services for individuals who need services? What is the structural context for how those services operate, what we need to build, and where it's going? And I'm just going to touch on these next few slides because there won't be time as I'm trying to shorten this presentation. But if you look at this slide, what you see in the picture is something that's crystal clear, focused in the center, and that's accentuated by the little text below that. So in 2011, and really through 2020, the state set about to try to create a vision for what the healthcare system should look like. It was focused on care management for all. It was focused on DSRIP, system integration, primary care expansion, value-based payment, all of those kinds of things. And it was a laser focus. I would say that within that focus, home care got pushed farther and farther away from what, if you were looking through that glass, what you might see in the centerpiece, but it was acknowledged as an important partner within the system. But then what's happened in the last few years? So at the conclusion of that first waiver period, what basically happened is that DSRIP was attempted to be renewed by the state. It was denied. The value-based payment waiver expired. The state health improvement plan that was funding primary care, new funding ended for that. Managed care, which is still in the focal point as a key part, is constantly facing policies that make it more and more difficult to actually operate managed care by things getting pulled out of it that really are part of the entire concept. Increase in eligibility thresholds that we heard about earlier today. The imposition of an independent assessor, which basically fragments what a nurse does, what a licensed professional does, which is to assess. That's part of the care planning and the care delivery. And now we have the state saying, no, we're going to take that out and let somebody else do it, who might see the patient twice a year. And if you are the clinician in the home with that patient, that's not your role anymore. So again, there's some real fundamental disconnects. And if you look at the picture in the middle, that's a picture of what macular degeneration looks like. If you go to the slide before, I'll see if I can make this work. You see the clarity of the focus. We might not have agreed with every element, but there was clarity there. If we look at there, we're really looking down the barrel of what has been a blurred vision, perhaps, and I think an attempt to recapture it. And if we listen to Greg really put together really a comprehensive array of all the great things that should be in place and where we should be moving if we're really going to address the needs. We heard discussion from Adam, and we've heard a number of times from Lou about the health equity waiver and the new direction in the 1115. That is also an attempt, I think, to recapture that focal point. So there you see the little scope on there again. But what is the 1115 waiver looking to do, and what does it hold? Again, I won't have time to go through the details. There are some slides in there on it, but we know it's aiming for a standard that we're all looking for, that we know is a societal priority, that burns within us as a priority, which is health equity, addressing disparities within the healthcare system, and ensuring that care is really delivered in the best possible way for our citizens. Invest another 13.5 billion. But as Lou said, in the initial waiver, $8 billion was invested in the system, and maybe a line that's barely visible went to community-based services. How much of that 13.5 billion is going to really build on what we know works? There was something in the chat. Someone responded in the chat, said, we know what the solution is. It's home care. We have it. Why don't we build on that? And that's exactly the question that we would ask. That's exactly the kind of comment that we're putting forward. I don't know if you'll see the words home care or hospice more than once or twice in that entire waiver plan. And so we are certainly looking to support all of the equity goals, but we also think that the funds and the vision of it has to be where people get their services, which is like what Greg had said. Most of the services aren't delivered at the institutional level. They're delivered where people get their services and live their lives at home in the community. So I'm going to move right now all the way to actually past. I had some fun slides for you. Maybe I'll give 1 second of the fun. All right. So part of the thing is when we talk about home care is to understand and speak in common, what is the home care space? Because very often we align it with a service, personal care or nursing, but actually the home care space is really as big as the scope of life that we're trying to support in the community. So the home care space is, of course, the home. It's the neighborhood. It's the community. It's the streets. It's specialty settings like assisted living and group homes. It's the emergency room where we have intervention programs. And it's literally on farms, mountains, valleys, and islands. This is a picture of the home care continuum, which goes from primary care to end of life, from infants and maternal care, again, to individuals who are in their last phases of life, who have complex medical problems and conditions. So when we talk about trying to make home care accessible to individuals and supporting that option, we're talking about that big picture. And it's important that the policy focus reflect that picture, not just ancillary initiatives that we sometimes see either in the budget or in other places. Because if you go back to the original slide that I showed you from 1977, that was an attempt at a coordinated focus of home care programming and policy in the state, not a bunch of ancillary, disconnected good ideas, but never connected to a place that's respected in policy. Here you have a picture that just shows home care really at the center of a lot of the management of what services and what the patient experiences is. It's not just about the delivery of one type of service or one element. It's connection with partners and diversity. So I'm going to skip these slides because you're going to have them. And I'm going to just go to, because I want to give time for our panel. Talk a little bit about, well, what is the vision then in this environment? So the vision of our association is really, it's really more comprehensive than just this one issue, but this issue really encapsulates it. It's something called Home Care First. It's the establishment of a home care first policy for New York State, something that basically requires the other policies to talk to this policy, that there's a central theme in the other policies, just like there is with age friendly, that home care is a part of the pivotal pillars of our healthcare system, and we need to make sure that that's supported, because when you destabilize that, it impacts all the other sectors, most importantly quality of life. So I want to just go over these provisions with you, and then I'll conclude. So in the Home Care First legislation, which has been introduced by Assemblyman Gottfried and Senator Rivera, it was advanced over the last couple of weeks. I know it's going to be a long shot to actually get something passed in what's really a very complicated 10 or 15 days left of the session. However, I'll just go over some of these provisions. So first of all, there are opening amendments to that policy that I showed you up front, that first page in 1977, that reinforces that policy as a focal point and a priority of the state. It also provides explicit statute that ensures that any individual, when medically appropriate, has to be presented and discussed with the option of care at home. Now, we know that we've got a little bit of a gap because we also have workforce issues, but I think we have to start with the right of an individual to know that there's an option available to them. The next part is dealing with rates and reimbursement. And we know that, that the system is years behind in adequate rates to support services. And that needs a standard applied to ensure that the rates that are paid to home care agencies, managed long-term care plans and others is adequate to meet the needs and goals of that kind of system. We need workforce support. So in this legislation, there's a comprehensive section that would target a financial assistance to certified agencies, licensed agencies, hospices, long-term home health care providers, MLTCs, anybody that's providing home care services is part of that. And that legislation is also directed to support recruitment and retention of all levels of service, all disciplines. And also there's a component of that that's specifically targeted at shortage areas and shortage disciplines. The next part is to include in all state policies and initiatives a consideration of home care. How often do we see a policy, for example, on primary care and prevention, and home care is not at the table, is not part of any of it? Capital financing, you can't find home care part of it. Sometimes workforce initiatives, you don't find home care to be part of it. So the idea here is to include home care as a critical component in the state strategies and policies, rather than have it be curbside or like it was under DSRIP under the category of other. So, and I just talked about capital and infrastructure, but telehealth is another important component. Home care was the first sector that had advanced telehealth, telemedicine in this state, and New York's law in 2007 was a national trendsetter for the country. Now, home care has been really left out of all of the other telehealth upgrades that you've heard discussed in the recent budgets. Well, we want to make sure that anything done in telehealth to actually create more flexibility, more benefit opportunity for individuals, that is synced with what is available through home care. Two other things. One relates to patient referral. We know that, in 1984, I was at LaGuardia Airport conference with Brian Hendricks from the State Health Department, and the whole conference was on discharge planning and why that was so important as a nexus for patient care and ultimately their outcomes. Here it is. It's what, 40 some years later, and we're still having that conversation. So this legislation also has provisions to address referral and referral protocols, whether it's from discharge planners or from physicians or other community sources to home care. Affirmative guidance, protocol, assistance, all along those kinds of lines, education.
Al, just a few minutes, Al.
Yep, I'll conclude. I just have these last two bullets. So the other part of it is comprehensive public education. And there's still a lot of information that's lacking in the broader public and even among health professionals as to what these services are, how do they work, how do you access them? And so this would really call for a very comprehensive set of steps to promote that. And the last thing I want to just mention on this list, and it's only last in the order, is access to coverage. We need to look beyond Medicaid, and we need to look at the cliffs created by Medicare to ensure that there's a more seamless coverage in these kinds of services. Otherwise, what we're talking about exists on paper, and it doesn't really exist in reality. So those are the components of the Home Care First Act. I'll leave that in the slide deck on federal. And there are some other images that follow. They really are opportunities that we're trying to promote and create in the home care field in terms of, like in this case, collaboration between home care and hospitals and physicians in terms of trying to improve the system. I'm working very closely with Dora and Haney's and Iroquois on that initiative. The virtual senior center that Greg talked about, trying to address isolated individuals through technology and to support them in a variety of ways. Addressing the nursing shortage through a nurse residency collaborative program that we're implementing. Addressing health disparities through home care. This is something that we've launched. It's got 5 different components in it, and we're really looking to try to leverage home care to make a difference in people's lives. And something that Greg didn't talk about today, but we always do talk about, and that's sepsis within the elderly, sepsis within the system. It's a huge, huge problem, and home care basically is in the position where 80 to 90% of sepsis occurs. So I'm going to stop at that. I'm going to stop at these slides because I know we need to go forward. But I think in order to approach this, we really need to have leadership and leadership cemented in the field. There's a leader right there. There's another one of my favorite leaders, which is Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. It's indeed the only thing that has. And one of my favorites, Vince Lombardi, basically saying, be fired with enthusiasm or you will be fired with enthusiasm. So fired with enthusiasm, I know this group is. I think we're ready to move to the next session. And I want to invite the panelists to come forward. And I want to thank you for listening to me in that part. And we'll now move to our panel.